Is the theatre ready?
Yeah,
So
madam,
we
the
go on to
theater
the
is
next live
ready.
surgery by
Yeah.
Dr. Vardhaman Kankaria,
Yeah.
who is going to be showing a live surgery on ICL. And I hope some of those smaller issues which could have been discussed now will be discussed during the course of the surgery. On to
Yeah.
you, Dr. Vardhaman. Vardhaman is again a very popular refractive surgeon who has does a good volume of cataract refractive surgery from Pune. He is the chairman scientific committee of the Maharashtra State Ophthalmic Society and is also the member scientific committee of AIOS. On to you, Vardhaman.
Thank you so much, ma'am. And first of all, thank you to Dr. Partha, sir, for the kind invite and an amazing show. A lot to learn from, sir, always. And great hospitality. So, friends, I'm going to showcase to you the Star Evo ICL procedure live surgery. As you can see, this is the ICL. It has come housed in BSS. So, basically, I'm going to just showcase to you. This is the what we call as the bottom applicator. And from that, I'm going to push out the pencil first. Can you see the video?
Is the video visible there in the hall?
It's visible. It's visible. Please go ahead.
And am I audible?
Yes, we can see it, Vardhaman. Please
Okay.
go ahead.
Okay, great, great. Thank you. Sure. So first,
So, what is the solution here from the ICL?
the solution is BSS. It comes housed in BSS. Now, this is the cartridge or the docking station in which I am gently going to load this lens. In ICL, I think 80% of the surgery is actually loading. As you can see, I'm not using any forceps. With a smooth round the clock motion of only this cotton tipped applicator, I have already loaded the lens in the docking station. I'm going to use what is now called as the front loading forceps. These front loading forceps are used to use bimanually, slowly pull this lens ahead. You have to be very gentle, grab it well, and with a swift bimanual motion, get this lens towards its step of the cartridge. Once that is done, now I'm going to actually assemble this injector system. And what you have seen these are the three holes of this ICL which are aligned well. So that means that ICL seems to be well loaded. Basically, ICL is one of my most preferred techniques right now. I have been doing ICLs for last almost 13 odd years, since 2010. And by far, there are a lot of phakic lenses which are available currently in the market. And I think more than 99% of my phakic lenses have always been ICL. That is my preferred choice of this lens. Now we are moving on to the patient. She is a wonderful 23-year-old girl who has -9 with -1.50 diopters of cylinder at about 10 degrees. She has an anterior chamber depth of 3.12 millimeters, and also the lens that we have chosen is a 12.6 millimeters sizes. Yeah. Can you keep your head slightly up better? Yeah, good. Thank you. Okay, I'm just.
So, it's always important to load the lens first and then go on to the patient.
Yes.
Do not take incisions or open up the eye before the lens is loaded.
Yes, absolutely. I agree 100%. Basically, because you want to be sure that the lens loading is good before you really touch the patient. And the lens loading, as we discussed, is about 80% of the job. Now I'm going to start the procedure. As you see, I'm going to do a one side port. I'm going to go towards the other side. Can I take a kuchi? Because I really don't use forceps. Thanks.
Anesthesia is preferred in these patients because of very high myopia, longer eggshell lens. So
it is very
safer
important
to do it under topical. The patient should be cooperative.
Yeah. And it is
You
also
can give an intracameral xylocaine. We do give patients.
yeah. Can I get the intracameral anesthesia?
Yes.
So basically, it is very important for all your maneuvers that they have to be parallel to the iris, because as cataract surgeons, we have been always used to have our maneuvers. This is the intracameral anesthesia that I've used, uh, which are towards the center of the lens, but in this case, it has to be always parallel to the iris. I always use the HPMC because HPMC is easy to remove, and this is the preferred choice of viscoelastic. You should still see the chains of viscoelastics and do not overfill the chamber. I am now going ahead and perform a 3.2 millimeter incision. Now in many of my patients I have now graduated to 2.8, but I think at least for beginning surgeons it is very important that we continue to have 3.2 incision for the ease of implantation. So now I'm going to, this is the assembly in my hand. It is very important that we actually inject this lens very slowly and not be in any kind of hurry. You can see.
Please center.
Yeah.
Cannot see.
Yeah, yeah.
Now this is opening up. This maneuver, my mentor Sonia Yu used to call as Mickey Mousing of the foot plates. When you have the Mickey Mousing of the foot plates, it is impossible for the lens to flip afterwards. So it is very important that you actually orient it very well. You can see the front loading foot plates are actually, Visco please. On the front loading foot plate, there is a small hole which is called as the orientation hole. And now I am putting some more viscoelastic that is over the ICL, that is to create some more room for myself.
And during the loading, injecting of the lens, in case you realize that the lens is turning upside down, then which rarely could happen, you can still pull out the ICL out and reload it and reinsert it.
Absolutely.
So it's very
100%.
important that the eye is centered. That's why Anaga wanted it centered so that we can all visualize how
Yes.
very elegantly it unfolded in the eye.
Absolutely, ma'am. I think I agree with you. And now I'm going to use this, what is called as a manipulator on my right side and a spatula on my left side. I usually use a manipulator which is designed by my mentor, Professor Palikaris, which is similar, has a slightly more rough edge on the downside. I'm going down now. I'm just going to put and tuck this foot plate below. And now this foot plate as well. As you can see, it is in its place. There should be no hurry, in fact, because we are in the anterior chamber space. As you can see, this is a toric lens. It needs a total rotation of 12 degrees clockwise. You can see this on Callisto. I'm going to go ahead and get the other foot plates in place. Super.
It's very important to see that all the foot plates are under the iris and the pupil is round. That is one clear way of letting us know that you have appropriately placed the foot plates behind them.
Absolutely, ma'am. So now I'm just going to make sure that the lens is nicely oriented perfectly well. Okay, then I give a small gush of in fact saline in the anterior chamber to remove some bit of viscoelastic. Can I get the saline? Yeah, thank you. So one of the reason I like this lens is of course because of its material. The Collamer really makes things very safe for the patient in long run. It's a very biocompatible material. We have seen there are a lot of advantages of phakic lenses. Now I think, yeah, please do not withhold your breath better. Keep looking straight. You're doing very well. Yes, thank you. So basically one of the advantages is that there is no dry inductions as we know, and there is no aberration which is induced, especially there is no aberration which is induced like in laser procedures, which is important when we are trying to treat high ametropias. You are not thinning the cornea, so chances of ectasia are 0. Of course, the most important thing is the quality of vision is excellent and the safety of potential reversibility. Okay, don't get startled. Okay, we are just putting some water on your eye. And now I'm going to remove this viscoelastic with a bimanual approach.
The central hole has a very important role in the removal of the viscoelastic also, and in maintaining the between the two parts of the chamber. So gone are the days where we used to do a YAG PI before phakic IOLs.
Yeah,
So with
absolutely. So the
the
central
technology,
hole.
new models, we
Yeah,
don't no longer do PIs now.
absolutely. So the
And
central.
again, it's very
For
important to remove all the viscoelastic as he's beautifully showing. We need to be sure that every visc puppet is removed. But I have learned it from Dr. Ramurthy, and I also use Helon regularly for all my cases. And I find I used to use methyl cellulose before, but now with the Helon, the huge advantage is it just comes out as a bolus. And this last few minutes, which is taking to clear all the methyl cellulose, becomes totally redundant.
Yeah, I agree with you, ma'am, because I think there is also a study by Netradama in which they have compared the HPMC with the Hilon, and Hilon comes out as a bolus, so it becomes very easy for it to be taken out. So it is definitely one of the choices, but I think one of the important points to make is that one should not use the dispersive viscoelastics like Viscoat. I think that should be contraindicated. That is something that we have to always keep in mind. Yeah.
The other question in this, before Dr. Sonu Goel, you could get connected. You are the next speaker, Dr. Sonu Goel. Dr. Vardhaman, you did a wonderful surgery.
Thank you, ma'am.
Would you think there is any role of hydroimplantation with phakic IOL?
So, ma'am, I think one probably should not be aggressive when it comes to phakic lenses. I have done extremely few number of this hydroimplantations, but I will probably not advise for beginning surgeons to think about that approach. Maybe one of the only places where I could potentially think is that if you have a very, very deep chamber and a spherical lens, you don't need much manipulation. I think that is one of the very few indications where it can be still possible. But generally speaking, no. I think generally speaking, I will still prefer.
I am also totally in agreement with you that with the care that we do not touch the lens even inadvertently, sometimes hydroimplantation could be a jerk. But I'm sure Dr. Ramurthy may want to add something. No. Okay. I think it's we need to be careful to protect the surrounding structures when implanting a phakic IOL. Beautiful surgery. I think he needs a good round of applause.
Thank you, ma'am. Thank you so much. Thank you for the opportunity, Dr. Partha sir, and wonderful moderation, Dr. Chitra ma'am and Dr. Anaga.